Okay. So, hi, good evening, everyone. Myself, Dr. Surya Kant, Professor and Head Department of Respiratory Medicine at King George's Medical University, Lucknow. I'm really thankful to the Chess Council of India, the vibrant organization of young budding pulmonologists, and it's a blend of budding, young, and experienced one. So I'm representing here the older category or the experienced category. So welcome everyone. And have you seen the old films? There was an era when you see on the screen at the beginning of the film that was written at the end after the casting that is screenplay, story, and direction by so and so. And here it also happens in Chess Council of India, the screenplay, story, and direction by none other than HM Krishna. So yes, Krishna, you are the great. And you are we love you too much. That's the only thing we want to convey from the CCI as well as from Lucknow. So greetings from Lucknow. Right now, I am in a hotel, not at my residence. Why? Because a international speaker program is going on. 3 international speakers just have spoken on COPD and asthma. And just I have finished my session as a panel discussion. And just I requested to the organizers that please open one room in the hotel so that I can, of course, complete my role of moderator that is given by Chess Council of India. And thank you very much for another stalwart, that is Narayana Pradeep. Both are the CCI chairman trustees. And I'm thankful to the president, Ashish Dubey, and the secretary, Anil Maske, as well. And you see, a man behind the curtain, man behind the all actions is Dr. Ravi Dosi, our beloved from Indore. Ravi, congratulations that you have reduced a lot of weight. I think you have become the role model for reducing the weight, especially for the doctors and those who have gained weight recently. And today we'll be discussing on very important hot talk. And this virus, as we have learned from the COVID-19, that also came from China. The news also came from this time also from China. And China is a mysterious country. They are not giving any information. So even the last episode of pandemic, that is COVID-19, the WHO has asked repeatedly so many information from China, but they have not given any information till date. So anyways, today is the 11th January, and what a coincidence that only 11 cases of human metapneumovirus they have been diagnosed in our country. So first and foremost, as a moderator, there is nothing to worry. Number 1, nothing to be panicked. Number 2, enjoy, be happy, just only take some precautions. So there are 3 messages from the moderator. And the flow of the program would be that first, I will introduce my panelists. So we have 4 important esteemed panelists, young, academician, vibrant. I was doing the biodata of these people. So I think they will become the stalwarts within few years. They are already stalwart because they are on the platform of CCI. They will become again experienced stalwarts also in next few months, next few years. So first is Dr. Ambika Sharma. She is assistant professor in SMS Medical College, Jaipur, Rajasthan. And she has a lot of laurels to her at this young age. And another is Dr. Ravi Dosi. Everybody knows Ravi Dosi. He is one of the important pillar of the Chess Council of India. I cannot forget 3 people at least because of my repeated interaction with the Chess Council of India. One is Vijay Chennam Chetty, second is Atri, and third is Ravi. These are the 3 important, my Hanuman, I would say. Because Hanuman is always ready, always they are the troubleshooters. So these 3, remember, 3 names I always remember: Vijay Chennam Chetty, the Atri from Ranchi, and Ravi Dosi from Indore. Another panelist is Dr. Dinesh Srinivasa. He is from Bengaluru, so he will represent that southern part of the country. And another is Dr. Parikh, Dr. Parikh from Amreli, Gujarat. So I think we have blend of very important pan-India panelists. I and Ambika representing the northern part of India. Dr. Parikh will represent the western part of the India. And Dr. Ravi Dosi will represent the center of the India and every part of the India because he is the revolving you see, of course, chair, I would say, in this webinar. And Dr. Srinivasa will represent the southern part of the India. So welcome, everyone. So first, I invite Dr. Ambika Sharma for her presentation. What is this virus? To which group we belong? Everybody knows that this virus is known since 2001. This is nothing new. There is an old saying called "old wine in a new bottle." That's what we can say. So I request Dr. Ambika, please share our PowerPoint presentation and update our audience regarding this new hot, most talked of the every town, this human metapneumovirus, HMPV.
Good evening, everyone. Thank you very much, Surya Kant sir, for the kind introduction. At the outset, I would like to thank Dr. N.H. Krishna sir for giving me this opportunity to speak on this such an important topic, human metapneumovirus. So, objective of my talk will be to understand and know the virus, how it is going to infect us, and if anybody gets infected with the virus, what will be the signs and symptoms? Can we diagnose it? And if we can diagnose it, is there any treatment and prevention for this virus? So let's understand the characteristic of human metapneumovirus. The virus is not new. It was discovered in 2001 by the investigators from the Netherlands. But mind it, the virus was present for more than 16 years, although it was discovered in 2001 and then it was put in the family called pneumoviridae, where the respiratory syncytial virus is also there. It is an RNA virus and has two subgroups called subgroup A and B. These subgroups also have two clades which are known as A1, A2, B1 and B2, which often circulate concurrently. I am mentioning about this subgroups because once we will be studying more about these viruses, we will be probably hearing that this time the circulation is of A2, 2.1, 2.2, something like that. So we need to be aware about the subgroups of this virus. Genetically, this virus is similar to avian metapneumovirus, but it is not an avian virus. So virus is ubiquitous. It is present all over the world and it has been there for more than 16 years and has a large global burden. In 2018, it was found that worldwide there were 14.2 million HMPV associated acute lower respiratory infections in children. So the virus is known to cause upper and lower respiratory tract infection in patients of all age groups, but symptomatic disease mostly occurs in young children less than 5 years of age and older adults or elderlies and immunocompromised patients. So let's understand how does this virus spreads. It spreads something similar to COVID virus that we all knows. It can spread by direct or close contact with the contaminated secretions, may involve large particle aerosols, droplets or fomites. Fomites means the objects wherever the secretions has been deposited. If we touch, whether it is mobile, doorknob or lift button, if it is virus has been deposited there by somebody is sneezing and coughing and other person touches it, there is the chance that he will also get the infection. Although there are also the few case reports that nosocomial infections can also occur with this virus. Once a person comes in contact with the virus, in 3 to 6 days time, he is going to show the signs and symptoms of the viral infection. And one important thing is that it is not an airborne disease or transmission. So virus has a very interesting seasonal variation. It is mostly occurring in the late winter and early springs in the US, the UK and other parts of Europe, late spring and summer in Hong Kong. So once the virus comes into the respiratory tract, it starts multiplying there and cause the airway inflammation, mucus hyperproduction and hyperplasia of the respiratory epithelium. And this can lead to mostly mild self-limiting infections, something like flu-like illness, which we also known as influenza-like illness or ILI. And then the symptoms will be simply fever, runny nose, stuffy nose, and a little bit of cough and sore throat. But sometimes the symptoms can be severe acute respiratory illness, and then patient may be presenting to us with bad cough, shortness of breath, chest pain, high grade fever, and wheezing. That means the patient is probably now been infected with bronchiolitis, pneumonia, acute respiratory distress syndrome, and maybe end up in ICU or on the ventilator. Sometimes these viruses can also exacerbate the asthma and COPD symptoms. Very rarely in children, it has also been reported the virus can cause encephalitis or infection to the brain. So, can we diagnose this virus? Yes, we can diagnose this virus by the same technique as we used to do with the COVID infection. Yes, that the test is called RT-PCR, which is most sensitive and commonly used method for diagnosis HMPV infection. Here, we are actually testing the viral RNA in human respiratory secretion, which can be nasal swab, throat swab, a sputum, or bronchoalveolar lavage from the lung. So another important technique which we are using nowadays is a multiplex PCR, also known as respiratory biofire or pneumonia panel, in which we test in one go many viruses and bacteria by the same technique. There are other ways of diagnosing HMPV, which are direct fluorescent antibody viral culture, but they require sophisticated labs and are mostly for the research purposes. Is there any blood test? Yes, blood tests can diagnose antibodies to the virus. But as I mentioned that the disease is quite prevalent in children less than 5 years of age, and it has been seen that about 100% of the kids by the age of 5 get infected with this virus and can have the antibodies. So it will not show the active infection. So RT-PCR stands the test of choice in cases of HMPV infection. So, what is the treatment for this viral infection? So, treatment is mostly supportive. That means if patients have fever, cough, cold, we are going to manage that. And there is no antiviral therapy till date. There is one antiviral which is ribavirin, which has been found to show antiviral activity against HMPV in vitro studies, but till date in vivo or there is no clinical data which has proven it to be used in infections with HMPV virus. Also to be noted that use of antibiotic is not usually indicated in the treatment of HMPV virus. Also, there is no vaccine till date, although there are the vaccine in the pipeline and they are in early stages of vaccine development. So prevention is the only way one should follow for preventing themselves for getting the infection. And the prevention is again the similar as we used to see with COVID infection. So one should wash the hand, use hand sanitizer, wear a face mask, and keep distance. So with this, I would like to summarize the HMPV virus. Again, I would emphasize that this is not a new virus. It usually causes a mild respiratory infection, nothing to worry. It is something like flu-like illness. Predominantly, children of less than 5 years of age and elderly get infected and symptomatic with this viral infection. Yes, we can test it. We can test it with the RT-PCR, but we don't have any antiviral medication available, so treatment will be only supportive. There is no vaccine till date, so prevention measures like hand washing, cleaning surface, and staying home when you are sick is the best way of preventing. And last but not the least, that India has not noticed any unusual surge of HMPV infection cases till today. These are my references. And with this, I thank you all for your patience listening. And now I would like to invite Dr. Parikh sir for his talk on other viral infections which are common in this season. Thank you very much.
Very good evening, everyone. Myself, Dr. Parikh, and it was excellent talk by Dr. Ambika. And I would like to thank Dr. Krishna sir and whole CCI team for giving me this wonderful opportunity to present on this current important topic. So my job is to give you some insight about other prevalent viral pneumonias. So these are the data from where it has all started just now. So CDC China, National Sentinel Surveillance of Acute Respiratory Infectious Disease, week 52, which means December 23rd to December 29th. Respiratory samples from outpatient influenza-like cases and hospitalized severe acute respiratory infection cases were collected. So you can see in that 10 virus has been collected. So not only human metapneumovirus, but RSV, adenovirus, parainfluenza virus, common coronavirus, and even mycoplasma was detected. So it is not just human metapneumovirus, but this all viruses has been increased in the China. So this is again the table from the same site, and it shows that week 52 compared to last week, you can see there is increase in influenza virus, respiratory syncytial virus, adenovirus, and out of which there is human metapneumovirus, along with parainfluenza, Boca, rhino, and mycoplasma pneumonia. So it is not just only human metapneumovirus, there is surge of every respiratory virus, including some bacterial and atypical pneumonia also. So this is a EPIC study 2015. So this study looked at common etiology for the community acquired pneumonia. This is basically US based study, and it has taken more than 2000 children for the study. What I want to show is you can see the upper bar. The first most common is human rhinovirus, influenza, S pneumoniae, which is bacterial, and the fourth I have marked red arrow, which is human metapneumovirus. So my point and the takeaway from this whole scenario and this whole webinar is it is not new virus. It was there. This is the study in 2015 and the data were collected in 2010 and 2012. So it was there, but just came to picture right now. So what are the common viral pneumonia in pediatric age group? So again, just to give you insight, I have quoted two studies. This Gabriel pneumonia study, multi-center prospective case control study, which looked at the microorganism associated with the children less than 5 years. And this study was even multi-country from Asia to Africa. There were 6 countries inside it. And what they found is, apart from S. pneumoniae, which is bacteria, RSV, rhinovirus, influenza, and parainfluenza virus are the most common organism. Second is the Perth study, which has been published in 2019 Lancet, which look at the severe pneumonia requiring hospitalization in children. So again, after the bacterial pneumonia of S. pneumoniae, RSV, influenza, human metapneumovirus, parainfluenza were the common cause. And if you go in depth of this study, they will say viral pneumonia are very less common that require hospitalization in children. And out of viral pneumonia, most of them required because of secondary bacterial infection or some complication because of that viral pneumonia, not just per se viral pneumonia. So in brief, I'll talk about antiviral vaccines for the pediatric age group. We all know poliomyelitis, measles, mumps, rubella are the disease very well controlled with the antiviral vaccines. Hepatitis A, B, rotavirus, human HPV virus, influenza vaccine, COVID-19, JE vaccine, yellow fever vaccine, and there is a dengue vaccine also that came into picture recently, but it is available only in US and Australia, not in India yet, but we expect that it will come. For the adult yearly influenza vaccine, and if you are keen to learn about it, there are separate CCI webinars available just on the vaccine, just on the influenza, and just on the various strain also. Then COVID-19 vaccine, then our gold COPD 2025 and 2024 suggest VZV vaccine for the prevention of shingles in age greater than 50 years of adult with stable condition, RSV vaccine for 60 years and above with the chronic heart and lung conditions, These are the vaccines available for adult also. So this is my simple talk, and what I want to convey is that viruses are on earth before our existence. Most viral infections are self-limited and don't require hospitalization. Hand hygiene, social distance, and mask should be the most important non-pharmacological measures. Don't be panic. However, awareness is important and vigilance is must. And I have small message for those who have joined first time to this webinar or CCI, or might be, seeing or listening recorded version. Be in touch with this platform, and this, like an antibody titer rise fourfold or more, is important. Your knowledge will surely increase fourfold or more. Thank you so much.
Okay. Okay. So I think now welcome to the panel discussion. I'm really thankful to the both speakers for presenting wonderful talk on the given topic. That is, Dr. Ambika presented about the virus and Dr. Parikh presented about the other viruses. So before I start panel discussion, I will share the experience of one patient from Lucknow. As I mentioned earlier, to begin with, during my opening remarks, that today is the 11th January, and coincidentally, we have the India has reported only 11 cases of HMPV, and one case has been reported from Lucknow. So I will just briefly summarize what happened to this patient. This patient, a 60-year female, having a lot of comorbid condition. Currently, she's on the dialysis, and she developed this infection, hospitalized in a corporate hospital, and she was suspected to be HMPV, as this is the time for HMPV suspicion. So sample was sent to a private laboratory, and sample was found to be positive with the RT-PCR. Then this patient shifted to a government hospital. I don't know why. Government hospital, not in my hospital. And then sample was sent to as we are the nodal center for any viral illness in King George Medical University. So this sample was sent from the government hospital. This was sent to the King George Medical University microbiology department. The first sample was found positive, and within 3 days, the second sample was sent. It was found negative. That lady discharged, now hale and hearty. Again, still she's on dialysis. So a kind of fear, a kind of panic I want to remove from the audience, from my dear friends, my community, and my fraternity, from both, that if an immunocompromised patient with renal failure, elderly female, 60 plus, if she could survive with normal supportive treatment, why should we be worried? Why should get panic? So with this opening remarks of panel discussion, now I coming to the question. First question, of course, to opening best person, the Ambika. Dr. Ambika, you have already presented that's called the human metapneumovirus. Is there any possibility that it's a genetic virus also, animal virus also, variety or something like this?
Yeah, so very interesting question, sir. And this is question probably we are thinking because once the coronavirus came and we were all thinking it is coming from the bat or it is the lab-borne virus. So understanding virus from where it is originating is very important for us also. For this virus, this is a human adapted RNA virus. So it is not a zoonotic virus, although it looks like genetically to the avian human metapneumovirus. That's why the names is human metapneumovirus and the avian, but they are both are separate. One should not confuse that it is coming from the birds. And this virus doesn't need any intermediate host like any animal or bird to propagate or stay for their stability. So from one human to another human, it can be transmitted directly. So it is not a zoonotic virus, sir.
Okay. So then the question is from Dr. Ravi Dosi. You see, people are now correlating with the COVID-19. A second COVID has come, can we face the lockdown? Now, a lot of calls coming to you also. I'm also getting similar calls and similar queries. That what will happen, sir? We will face again lockdown. We will again face the online UC work and among so many queries. Do we get some oxygen cylinders or oxygen concentrator to be purchased for my family? Do we get some reserve ICU beds in a private hospital like this? So, Dr. Ravi, can you differentiate what is the difference between this current HMPV and the COVID-19? Ravi.
Well, sir, COVID-19 virus, like in bulk of the COVID-19 virus cases were also mild cases, and there were only some proportion which were going to moderate and severe, causing respiratory failure. They were more so in the first and second wave, and then the virus mutated and became more mild. So this human metapneumovirus is also behaving like that only, which causing an initial acute viral phase, and then it is subsiding very quickly, not causing very high severity as was seen in few cases of COVID. So COVID can be considered a relatively more virulent virus as compared to human metapneumovirus, which we are facing just now. Both are RNA viruses, and the relative epidemiology of them are similar. Both are affecting the children and elderly and immunocompromised more. But presentation of COVID-19 was more rapid and more severe as compared to the human metapneumovirus.
Okay, Ravi. In a nutshell, we can say regarding the infectivity, regarding the speed of transmission, and regarding the morbidity as well as mortality, COVID-19 is far ahead, far dangerous. We have not seen any kind of, you see, the first few cases which were reported from the Bengaluru and then Ahmedabad, they were the first 3 cases. They were the kids, not only kids, they were the 3 months, 6 months, 9 months old children. And they could survive. One, I still remember that one can survive even after developing pneumonia. One developed acute bronchitis, acute pneumonia, and still they survive. So one thing is clear that everybody should know that whosoever is attending this webinar and will attend on YouTube, we should become the advocate of anti-panic campaign. Of course, that is going on with WhatsApp University, with the TV channels, because they want the increase the TRP reading. Fir aaya corona, fir machayega corona. Among such type of lines, headings we are seeing on the TV channels. So I think we should become the advocate of Chess Council of India and this webinar, and strongly should condemn by media, social media, electronic media, print media, verbal communication, by seminars, by presenting your lectures, everything. And there should be no hue and cry. And another thing which I want to say that India has managed COVID-19 very confidently. If you compare any country, any part of the world, that is developed world or developing world, India contained COVID-19 very effectively. When COVID started, we were not having any facility for making ventilators, the N95 mask, or anything. Now India is making everything. We are making ventilators, we are making N95 masks, we are having everything. The oxygen plants have been, increased so many times. A lot of health infrastructure related capacity building has been done in India. So now 5 years ahead. So now we are more confident regarding any health emergency. So believe on your doctors, believe our own health infrastructure, believe upon our own leadership, and believe our system. And nothing will happen to you. We doctors from Chess Council of India promise you that don't be panicked. If at all there is any problem, if we could handle the lethal emergency like COVID-19, we can handle anything now. So don't be, India is not of, the earlier 20th century, we are in 21st century, and the India had changed a lot. So coming to the question again to Dr. Ambika. I'll ask 2 questions in a 1 question. They are interrelated. So what are the contributing factors for this upsurge? Especially we are seeing from China and some other countries, we are not seeing any upsurge. You see, within almost 2 weeks happened to the China upsurge, but nothing such kind of upsurge is seen in India. Anyway, any other contributing factor, and what is the seasonal variability about this virus?
Yes, sir. So, again, this story, I think we'll again start with the COVID thing. So it was a COVID time when everybody was using so much of precautionary measures like using masks, not going in the crowded space, hand hygiene. And at that very time, we saw that most of the viral infections were disappeared. We were not seeing influenza and respiratory or HMPV virus. But once these restrictions has eased and people are now going more around and the viruses are also coming back, we are hearing every seasons, last year also there was a discussion with the HMPV influenza strains and all kind of. So we can call it the viral rebound phenomena, and over last 2-3 years there was a little waning of the herd immunity. So when this virus is coming, so we are now getting infected again, and some are symptomatic also. So this is probably the viral rebound, one important reason. Second is now we are using nice diagnostic methods, for pneumonia panel, respiratory biofire, and we are picking it very quickly. Now the cases of severe acute respiratory infections, especially this has increased in popularity after post-COVID. We are doing quite often this test. Third important thing is the surveillance part, and all the countries, I would say China, as they saw there was a rise in the case of HMPV, although they are saying it is in the seasonal trend only of the virus, but they informed to the CDC, they informed to the WHO. Now the whole world know, and everybody is vigilant and talking about that how is the pattern in their countries, and we need to timely inform this thing. So these are three important things: global reporting, surveillance, diagnosing it early, and the post-COVID waning effect and viral rebound phenomena, which has lead to increase in awareness and number of the cases of viral infections. Third is the seasonal variability. Is yes, this virus has this favor for the late winter and early spring, something like respiratory syncytial virus and influenza virus, who also prefer to grow in the winters. And reason for this is the same, that they love the cooler temperature and less humidity environment, which helps them to stay more stable and replicates nicely. And the important thing is that in winters, people prefer to stay indoors, and the transmission of virus it become more prominent in this particular season. So I think virus stability is good with this season. That's why they prefer it to be seasonal.
Okay. I think Dr. Ambika has cleared a lot of clouds, I would say, in the sky regarding the seasonal variation and regarding the other contributing surge factors. So now I'm coming to Dr. Parikh. Dr. Parikh,
Yes.
You see this webinar is also covering the other viral infections and pneumonia. So there are two questions combined in one question. First part is, what are the other common virus infections and what are the other viral pneumonia?
Sir, winter is a time when all viruses rises. I showed that slide also in China. They are though propagating more on human metapneumovirus. They also declared that there were rise in all viruses, including some atypical pneumonias of mycoplasma also. So in my part of the world, I am seeing a bit of rise in influenza H1N1. Then there are few like RSV and para-influenza, which are not that much serious. They are coming on OPD basis only. But due to the availability of multiplex PCR, pneumonia plus panel that madam and you were talking, we are detecting it. They are milder, not requiring any hospitalization. Just very few cases of H1N1 which have bilateral lower zone pneumonia and hypoxia. And with the case you mentioned, comorbidity, sometimes they require hospitalization and O2 support. Otherwise, there is nothing much to be worried. And I think we see all year, all winter, such cases are rising.
Yeah, thank you, Dr. Parikh. I think so. We are facing the viral infection not for this year. We saw for so many years because the winter is, of course, the lovely opportunity for the viral infections. They are coming without an invitation. We don't have to print or WhatsApp the invitation cards for them. They are the coming without invitation, uninvited guest, I would say. The Dr. Ambika, again, question to you. Now, problem is this, that if there is no new mutation to this virus, we don't need to have any panic. And we have observed there is no new mutation have occurred. Now, does this happen to the China because of, that's why there is an upsurge? We don't know. So is there any possibility of mutation in the virus? Because you said that for 60 years we are experiencing this infection, and this is like coming and going, nothing happens especially. So there is no evidence, or is there any evidence that there is a mutation has occurred to this infection that has leading to the increased surge, increased infectivity, or increased severity? Dr. Ambika.
So yes, with every virus, sir, we know these are some of the viruses which are always there, and especially with the RNA virus, they are notorious for having the mutations, and any of the mutation can be very virulent and infective. Also, as this we have seen again with the coronavirus also. So anytime whenever we will see the upsurge of virus, we always keep a track on that, is it the mutant variant, it is a very infective variant. But till date I have not come across any evidence for this time of HMPV virus has got any mutated and has become very infective. Not the reports has come from the China or WHO or CDC, or not even from the Indian authorities. So at the moment we are not expecting any mutant form of this virus, sir. But anybody from the panelists can update me about this if I am not updated very much.
Yeah. Any panelists want to give input? Any evidence coming for this mutation? So I think no. Okay. Now again, I'm coming to Dr. Parikh. Dr. Parikh, before I coming to the treatment of this viral infection, is there any role of antibiotics? Is there any at all role of antibiotics?
Sir, this is a question which is answered very easily, but not practically done by many people you know very well. So when I say and we say there is no antibiotic and antiviral or viral infections, you have seen that many has prescribed and will continue to prescribe. Might be the fear is that patient don't get easily convinced that the symptomatic treatment will resolve our viral infection. But the thing, I also want your input also, but the thing I feel is the doctor has to be first convince himself that it is viral and it will resolve with my symptomatic treatment. Then he can always counsel that it is a viral infection and you need not to be worried. This symptomatic medication, rest and hydration will cure you unless there are grave signs, there is comorbidities, hypoxia, then you need to visit the doctor. Antibiotics are used when it is complicated viral pneumonia with some bacteria. So when there are purulent sputum, when there are yellowish sputum are there, when the chest X-ray shows some lobar collapse, lobar consolidation, some consolidation with effusion, increasing WBC count, these are the indicators that your viral pneumonia has been complicated with the bacterial pneumonia. Then you do according the investigation, the culture, and you start empirical antibiotics. I think this is the only phase where antibiotics are required in viral infection. But my mentor says that walking the talk is the most difficult exercise. So when we say no antibiotics, many don't follow it.
Yes, I think you have put the all perspective in a very right manner. This HMPV is a self-limiting infection. It does not require any treatment except the bed rest and hydration, as mentioned by Dr. Parikh. So this virus is basically giving you alarm that you have not taken the rest of 1 week. Please take the rest of 1 week, have the hydration adequate, and take the symptomatic treatment. If at all fever is there, you can take paracetamol. If at all cough is there, you can give simple cough preparation. That's all. Nothing. So, and Dr. Parikh has specifically mentioned there is indication of antibiotic when there is a clinical parameter in terms of purulent or yellow or this sputum is there. Fever is there, which is of entirely different from the viral fevers. And this TLC is increased and neutrophils are increased. That's also usually in viral infection, total leukocyte, they are decreased. While in bacterial infection, the total leukocyte, they increase. So that simple test, TLC, DLC can differentiate whether this is viral infection or this bacterial infection. And then presence of sputum, as mentioned by Dr. Parikh. So I think we should not misuse antibiotic, because misuse of antibiotic is another important issue that can be a topic of CCI. The only thing is when you hospitalize the patient, the comorbid condition is there, elderly are there, patient has developed pneumonia, then of course in anticipation, you can start antibiotic. Nobody can afford that patient is hospitalized in ICU, having diabetes, having other comorbid condition, and you will not start antibiotic because Dr. Surya Kant or Dr. Parikh or CCI webinar is saying. Then, of course, you can start antibiotic because this is the high time when you have to save the patient. So, yes, you can start antibiotic. Yes. So, wonderful. Yes, but we should be the crusader for creating the awareness regarding the misuse of antibiotics. Also, we should have proper indication for using the antibiotics in such condition. Now, the question again comes to Ambika. What is the current treatment of this infection, and is there any emergent therapy?
So yes, sir. So treatment is supportive. We don't have any antiviral at the moment for treatment of HMPV infection. So supportive means if the patient is having fever, cough, cold, we are going to give antibiotic and cough syrups and symptomatic treatments. And we will keep a close watch on the dangerous sign or warning signs like, in the kids, if there is a retraction of the chest and ribs and there is hypoxemia and increase in breathlessness and decreased saturation. So one should keep these patients in close observation, and probably they will be ending up in the bronchiolitis or in pneumonia. Especially the patients who have atopy and allergy asthma, they can have a increase in their wheezing symptoms and asthma exacerbation. So we are going to manage them according to their symptoms. There is no definite treatment for any antivirals, although as mentioned in my slide that ribavirin is in the experimental studies and has shown in vitro, but there are one or two case reports where people had tried to use this, but there is no recommendation to use this antiviral, and we have to wait till the time any antivirus therapy is available. And along with that, in the emerging and in the pipelines are the autoantibodies to be immunoglobulins to be used in these cases, but they are again under study only. So at the moment, only supportive treatment is available for the patients who have HMPV infections.
Okay. So, hi, dear Dr. Dinesh. He's waiting from Bangalore. So, coming from the northern part and the western part of the India and central part of India, coming to the southern part of India. Hi, Dr. Dinesh. The question for you is, what is the role of currently available antivirals for HMPV?
Good evening, everyone, one and all.
Yeah.
I don't think so there is any role for antivirals as of now. Giving them only symptomatic treatment would be better rather than giving them, because this virus acts only as an RSV. So until and unless it is proven otherwise, I don't think so there's any role of antibiotic or antivirals in this.
Okay. So you rightly mentioned that there is no role of currently available antivirals. There is no proven study and no proven even experience also. We are giving only supportive treatment. So again, this question to...
Sorry, if I can add, getting a lot of pediatric cases as well. In fact, even today I had almost about 3 or 4 patients in my evening OPD, where it only looked like an RSV and not and like an HMPV or whatever. But we are not testing them to really see if they are positive or negative. So we just treat them symptomatically until otherwise indicated. And just leave them at that. And usually they respond, the virus takes its own term, maybe about 7 days or 10 days. They usually respond by then. And we can just leave them.
So yes, bed rest, hydration, and symptomatic treatment. That is the key of treating all viral infection, except a few where a specific antiviral infection is available. Antiviral treatment is available. Now, Dr. Ambika, this is the last question for you. What are the preventive measures you will suggest for this infection?
So again, we all know all the preventive measures. We have learned it by heart during COVID time, and the same is going to apply here. Wearing a mask, doing the hand hygiene, not touching your eyes, nose frequently, and avoiding the crowded space. If somebody has symptoms, one should isolate themselves and not to spread the infection everywhere. So this is the thing we can do for preventing the spread of the infection, sir.
Ambika, what about shaking hands? Because every time we meet, we have forgotten Namaste, we are shaking hands. What about your opinion?
We have to again come to our Indian tradition of joining the hands and saying namaste instead of, and I don't know why we again forgot this. We are just immediately moving to the westernization. We were following this in COVID time, and it's the time again that we should follow our culture and avoid shaking hands, because if the person is getting infected, it can transfer the infection and secretion to other persons. A very important point brought by you, sir. Thank you very much.
So I'll give you my example. I just here in the hotel, around 200 people are there, 200 doctors are there. So just not to humiliate them, what I am doing, that whenever the people coming, so I said namaste. आजकल नमस्ते ही करते रहिए, बोल दीजिए अपने आप. So before he's giving hand to for shaking the hands, do the namaste. So that is the only way. So somebody should not feel humiliated that you are not shaking the hands with, and he is offering for shaking hands. So that is my personal way of avoiding these shaking hands. I say namaste, और आजकल तो namaste ही चल रहा है. Yeah.
It should be a message of the day, actually, I feel. It is the need of the hour also.
So learning is by two ways: evidence-based and experience-based. And probably Krishna had chosen me by sharing some tips of experience-based learning. Evidence-based you are presenting. So I'm coming to now the Dr. Ravi. Dr. Ravi, you are the community man, always making awareness people by your videos, by your YouTube channel, by your writings. You are very community-friendly for awareness. So what should be the community prevention perspective, Dr. Ravi?
Most importantly, sir, we need to highlight this fact that this virus doesn't warrant that, even in the warrant a lot of scare to be there in the community. And like you very correctly told, the moment it came up front, lot of interesting headlines and fears, and a lot of WhatsApp universities started working to spread that phobia again. So I think the work should be at a community level by the medical college, where they should teach properly that this is the basic of the virus and this is the prevention method which is there. At the hospital level or at the OPD level, we should start propagating that cough etiquette and vaccination of known viral illnesses is better. And at a personal level, I think we all are part of the WhatsApp community, part of several social groups. And whenever such news is being shared, I think it is our responsibility to take care that this fake news doesn't spread from any group that we are part of. I think that is very important, that even the YouTube recording of this particular webinar, we will be shared and we should post in all our groups so that we can spread the correct message that this virus is there, but it can be taken care of, and there is no need to create hysteria about any other virus. Because like Surya Kant sir told, that thanks to our management of the COVID, now we are in a much better position to handle any threat which comes to our health.
Yeah, thank you, Ravi. Now question to Dr. Dinesh. Dr. Dinesh, what is the current treatment of H1N1 influenza? Because that is more common, prevalent rather than this HMPV.
Yeah, in fact, even the early of last year, we saw a lot of H1N1, H3N2 cases, which we are presently seeing as well. Even now, being in Bangalore, right now it is also cloudy and the temperature has dipped to around 10 degrees here. So we tend to see a lot of patients who are elderly or comorbid, have diabetes or even renal transplant, because I take care of the ICUs as well. So I keep receiving such patients, be it tumor or receiving. So there are a lot of H1N1 cases as well. Yes, the present thing is we give them symptomatic treatment, do the flu panel, and if it turns out to be, maybe you can start the antivirals depending on the renal functions. And probably oseltamivir is what is chosen as the oral one, which is easily available, which we do give. Antibiotics only if it is preferred, or any other, the counts are more. Otherwise, we don't give them any. Otherwise, it's just a symptomatic treatment, even in immunocompromised patients.
Yeah. So I'm coming to Dr. Parikh. Dr. Parikh, you see, whenever you talk of any infection, people talk of vaccine. So this is also frequently asked question. Doctor, vaccine is available or not? So yes, right now there is no vaccine for this. Can you comment on regarding the vaccine perspective of this HMPV, Dr. Parikh?
Yes, sir. Sir, before I answer your question, I would like to say two things. First is Ravi Dosi sir plays and put a role play like scenario very often. And if you
Yeah.
just see that role play, you get awareness. Even laymen get the awareness. So I'm really inspired, and I even shared that video. That it is a very small videos, 1 or 2 minute, and it really inspired the community. So I like to congratulate Ravi Dosi sir for creating that awareness. And second is Dr.
Congratulations, Ravi.
Krishna.
Yeah, congratulations to Ravi. Yes.
And Dr. Krishna sir just messaged that there are 4,325 live logins at present. So all hails to CCI for bringing this topic at present and creating such awareness. And to answer your question, sir, there are pediatric and adult, but we remain on the current topic that there are no HMPV vaccine available at present. However, there are vaccine available for other viral infections like influenza, which is most common, and I think we all take it yearly. And it is available for both adult and pediatrics. There are vaccine available for COVID-19 viral infections. There are vaccine available for I also presented that MMR vaccine, poliomyelitis for children. We are also taken in our childhood also. And there are vaccine like RSV vaccine, yellow fever vaccine, Japanese encephalitis vaccine for the high risk newborn patient that Dinesh sir can even take it, that which other vaccine can be given. So I think influenza vaccines are in adult, and I have showed that in Gold 2025, they say shingle prevention through VZV vaccine for age greater than 50 years of age, and RSV, which is not available yet in India, I guess, and for the 60 years of age and ahead. So these are the antiviral vaccines available in India.
Okay. So now the time for the questions from our dear friends who have already logged in for this webinar. And there is a question from Ashwani Sen from Madhya Pradesh, Indore. So there will be bias of the city. So I will not ask this question to Dr. Ravi. I will ask to Dr. Ambika. What about the spread rate of HMP virus? Dr.
Again,
Ambika.
again, very interesting question, sir. And when I was also like coming for this webinar, I was thinking, what is this spread rate of this virus? Because during COVID, we were learning a term which was called R0, or reproduction number, and this is statistically how people calculate the infectivity or spread rate of infection. So the spread rate of this HMPV virus is similar to influenza and RSV, that is respiratory syncytial virus, which is around 1. The R0 value is around 1.5 to 2.5. That means one person can infect 1.5 to 2.5%, or 1 to 3. We can roughly remember it like that. But if we remember the COVID time, so COVID time, the number was 5 to 9, depending upon which mutant was there at that time. That means one person can infect up to 9 persons. So in that way, the spread rate of this virus is relatively low compared to COVID. And I think in the studies, I think measles is the highly infective virus and can infect, and one measles patient can infect up to 15. So I think infectivity rate and spread rate is quite not very worrisome. It is 1 to 3 persons. One infected person can spread to susceptible persons.
So I think nothing to worry, and that's why we are seeing that within 2 weeks' time, India has reported only 11 patients, and nobody has died. So that kind of assurance we are giving again and again, that please, whenever you meet, greet with Namaste, number one. Whenever you do go into the crowd, wear a mask, and if you don't have the mask, take a hanky, take a stole, or take a gamcha, whatever you have, and make a ready-made mask. And just whenever there is an opportunity, wash your hands. So among such kind of, and of course you can take steam inhalation at the end of the day. So these are the 3-4 measures which you can present very well by practicing this. So nothing to worry. There is a not question, but very good comments. So Deven Gupta from Delhi, he's saying, congratulations, Professor Surya Kant, for this excellent webinar. Thank you very much personally, but don't say congratulations only to Dr. Surya Kant. Say congratulations to the CCI Chess Council of India, and it's a founder, trustee, Krishna, and so many UC, our panelists, Ambika, Ravi, Dosi, Dinesh, and Dr. Parikh, and of course the whole leadership of the CCI. But thank you very much that you are giving appreciation to all of us. He's saying that this is an excellent webinar. And do share the recording. I must be thankful to the Cipla team, technical team, that I think the YouTube recording will be posted, and we will disseminate this YouTube recording. So another question is from the Aditya Kushwaha from Rajasthan, Jalore. How to triage and diagnose or suspect in general OPD and treatment protocol. Dr. Ravi, yes? How to triage?
Yes, well, triage will definitely be on the principle of physiology. Means if the saturation is falling, or see, we can divide it into common symptoms. The common symptoms which the patient will present with are cough, nasal congestion, sore throat. He will have high-grade fever in a short span of time. In only severe cases, you will see that the patient might be tachypnic or having wheezing. In children, they may present with bronchiolitis or pneumonia. And these are the cases in which you should suspect, but they are similar to all other viral pneumonias. There is no exclusive symptom which is attributed to HMPV. There are few red flag signs in which you need to consider them as severe cases or cases warranting admission for observation. They are fever not responding for more than 48 hours. If the patient is having a respiratory rate of more than 30, or he is tachypnic with respiratory distress, or the child is having refusal to feed, or if you are having abnormal blood pressure and low saturation. These are the red flag signs in which you need to consider this as a severe case warranting admission for observation and stabilizing with routine hydration and oxygen.
Great. Another question is from Ankit Singh, Delhi, that what vaccine-related research is going on at HMPV at the moment, and does it really require a vaccination in future? Dr. Parikh.
Sir, there is one vaccine on phase 1 that is currently the research is going on, but I don't think that it requires vaccination in future. But since COVID has given a turmoil that any viral infection can spread like epidemic and pandemic, so if it is so much severe, the HMPV viral vaccine virus infection, then probably we may require. But at present scenario, seeing this condition, I don't think there is any need for such vaccine as such.
I have something to add in this, sir.
Yeah.
So for vaccine, sir, because this is a common virus, and the data says that US data by age of 5, 100% of the children get infected with this. And if we see the severity, only the less than 5 immunocompromised and elderly get the severe infection. But the ratio of getting severe infection is around 5 to 15% can have, really symptomatic and can end up with going to the hospital admissions. So, and another important thing is there is no antiviral therapy for this. So here comes the importance of vaccine. If the vaccine comes, so it will be good that we can even prevent that getting severe disease of 5 to 15% in small kids. So when there is no antiviral, vaccine should be in the pipeline and should be come in the market. I feel so that in personal way, but yes.
Okay, Dr. Ambika and Dr. Parikh. Another question is from Dr. Sunita Yadav, Uttar Pradesh, Farrukhabad. You see, Uttar Pradesh has got 75 districts. Farrukhabad is very close to me. Publicly, I can't say, but some other day I will tell you why Farrukhabad is very close to me. But question is, what we can do for protective cough? Dr. Dinesh, can you answer this question? Usually there is a dry cough in this virus, but if there is a protective cough, what things you can advise to the patient?
If the patient, of course, first thing is you do the chest X-ray on the total count and see if at all it is bacterial or virus. If it is bacterial, you start the antibiotic, and if need be, and if the patient is asthma, COPD, or bronchiectasis, you can start them with the inhalers or nebulizations accordingly to the concerned thing. And even if it is virus, I would still say do a chest X-ray and CBC. And if it is virus, give them some nebulizations and antihistamines and antileukotrienes, and if necessary. So, but yes, if they're getting out the phlegm, it's a good thing. Just tell them that it is a process of the thing and that they are going to get well, and give them a good amount of nebulizations and antivirals if necessary.
Yeah. So I think protective cough, this should be managed on the line of that whether this is associated with the phlegm, the sputum, which is yellow, which is dusky, or which is greenish. So I think these features, they suggest the secondary bacterial infection. And then in such cases, you can add the antibiotic, proper antibiotic. And yes, steam inhalation is a very good thing which should be used for the protective cough. And if the patient is also having wheezing or the bronchospasm, then of course expectorant cum bronchodilator can be added along with the ciprofloxacin or N-acetylcysteine. So I mean, these measures can be taken. And Dr. Sunita, don't worry, you are from Farrukhabad, Uttar Pradesh. You can call directly to me. Okay, now next question is that is from Ashok Kumar from Madhya Pradesh, Indore. Anyone have experience of seeing a patient? Yes, all the panelists. Anyone who has seen the patient? I have the one experience of observing only the data, a report, that's all. The patient was not hospitalized. The Lucknow patient was not hospitalized in our hospital. Any of the panelists?
Sir, previously we have seen a patient actually some few years back, but
here we have all seen the patient. Yeah.
Sir, I have known one doctor who came HMPV positive 4 months before.
Okay.
Just viral infection. He is a chest physician, so he does the RT-PCR from nasopharyngeal swab, and he posted in our group 4 months before that I have HMPV virus and nothing to be worried. He just takes symptomatic and resolve. He is known to me, nearby, residing nearby me only. So not at present, 4 months before.
This virus has been there for quite some time, so I don't think so. You really need to do a test for this. You just treat them as a upper respiratory tract infection, and only in comorbid conditions you go ahead and treat them. I don't see any necessity for you to test these patients. I mean, suppose, of course, it is my perspective. I don't see any reason why we need to really see, if at all, it's only if there are any comorbid conditions or, in the transplant, or cancer, or diabetic, or uncontrolled diabetes, Even there are so many other immunotherapies and rheumatology patients. Only then I think, okay, fine. But even then, only if it is really necessary. Otherwise, I don't think so. It is really need to really test the patients unless you are really suspecting any other virus. If it is just a common cold, you just treat them as such and leave them. And if at all they're an asthma or COPD, give them the inhalers and appropriate inhalers and antibiotics as the GINA guidelines says. Otherwise, I don't think so. It is really necessary to do antiviral therapy. Of course, immunizations is a must. Go through the immunization chart and explain them, and then leave it at that. That's my perspective.
Yeah. Now, I don't have any question in the chat box. Is there any tactical team who is looking after the questions? Is there any other question left from the delegates?
All answered.
Okay. So again, Dr. Sunita Yadav has congratulated and giving thanks to the whole team and personally to Dr. Surya Kant, me also. So I think this is the time to summarize. So a single liner, one conclusion from every panelist, starting from ladies first, Dr. Ambika.
So again, this is not a new virus. So somebody has asked that, have you seen this virus? Any of the panel? We all have seen this patient. Probably we have not tested in every season. The patient with flu symptoms are coming, especially in the winters, influenza, RSV and HMPV. They are all there. Only when the patient gets hospitalized with severe pneumonia and have a severe acute respiratory illness, then only we do this kind of, respiratory biofires and try to find this case. So this is a common, and we are seeing it, and we are managing it on an OPD basis only.
There is one more question from Soumya Dwivedi, Farrukhabad, Uttar Pradesh, to you only. Although you have presented, I think she has logged in late. So briefly, again, just tell us what are the symptoms and signs of this HMPV.
So usually it is a mild infection and it presents like influenza-like illness or flu-like symptoms, like patient may have body ache, fever, cough, cold, coryza, and when the symptoms are really severe, that occurs only in 5 to 15% of cases, and persons who are immunocompromised or very elderly or less than 5-year-old age, where there it can present as bad cough, shortness of breath, wheezing sound, very alarming in children. When the wheezing starts, then doctor should be aware that this patient can go in bronchiolitis and pneumonia or in respiratory failure. So these are the signs and symptoms we can get of pneumonia. When we auscultate the patient, we can hear the crackles and decreased saturation. So these are the common respiratory signs and symptoms which we see with most of the viral infection. We are going to see that, and the red flag signs are also same, whom we have to admit and put or they will be requiring ICU or any other higher medications and supportive care. The sign symptoms are quite similar to other respiratory infections, sir.
Dr. Dinesh, before I ask you regarding the one-liner, your brief summary comment, there is a question for you. Is there any role of steroid in this viral illness?
Oh, that's a difficult question.
Yeah.
Yes. But only if as you said, it's a productive cough or non-productive cough, if it is not going away, it is really irritant. I mean, you only think of it in the last resort, and I usually don't give it. Give them good nebulizations or the inhalers, if at all they are really good at taking it. I don't see the role of steroids, but only and only if it is required. That is in the end, if the cough or the other symptoms don't come down. But otherwise, I don't see role of steroids really in there.
Yes, so actually role of steroid is always universal. I mean, the indications are always universal. So whenever you feel that this is the terminal care, the oxygen desaturation is more, and you are seeing that the marker of inflammatory markers, they are gone very high. So of course, then you can use that is the universal indication, not specific to this virus. As a part of supportive management, as a part of terminal care, when the patient is very sick, you can use. Dr. Dinesh, your single concluding comment on this webinar.
Take, as you told earlier, take the precautions and be careful in the overall thing. And also when you sneeze or when you cough, look down and sneeze, which I would really comment. Otherwise, just be vigilant. If at all there are saturations dropping in or whatever, only then really think of it. Otherwise, just have an upper respiratory tract infection, which will usually resolve by itself.
Yeah, thank you. Thank you, Dinesh. Thank you, Ambika, and thank you, Dinesh. Dr. Ravi, your concluding remarks regarding this HMPV and this webinar.
आज के वक्त की यही पुकार, नमस्कार से प्रकट हो आभार और प्यार.
Wow, क्या बात है. Dr. Ravi, you are wonderful. So Ravi is basically a man of the community, and that's why we think of that he's the right person for the advocacy, for the awareness, and for convincing the people. So he has already given message that namaste kariye aur bachte rahiye. So thank you, Dr. Ravi. Now coming to Dr. Parikh. Yes, anything from your side as a message, final message?
Viral infection is always 80 to 90% will be treated with symptomatic, rest, hygiene, and maintaining cough hygiene only. So don't get panic, be aware, be vigilant, but don't get panic.
Okay, thank you, Dr. Parikh. So I think in the nutshell, I can conclude that this viral infection is not a new infection, number one. This virus is not having too much power of the transmitting in the infection. The speed of transmission, the power of the transmission is very low. The morbidity, the disease created by it, it is not too cumbersome. It is not too morbid. So, and usually this usually infect the younger children, less than 5 years. I used to say Bachpan and Pachpan, both have to be protected. So this message is also applicable here also, that protect Bachpan and Pachpan. Pachpan means the senior people. Pachpan is 60, same thing. And Bachpan is usually childhood. So protect the childhood and the senior people, Bachpan and Pachpan. And use the traditional way of prevention. For example, namaste, the washing the hands. And one Dr. Dinesh has mentioned rightly that whenever you are sneezing or cough, your neck should be get down, so that whatever the droplet nuclei they are coming, they should not go to the opposite side fellow. They should go, of course, or you can cover with your this thing arm, the nose and mouth. So these are the acute way or the transient way or the ready-made way of probability of cutting down infection, especially if you are sneezing and you are not wearing the mask. So ideally you should wear it. And as Dr. Ambika has rightly mentioned, the R value is very high. Infectivity is very less compared to the COVID-19. So this here, the one person can infect the 1.3 on an average. Usually I can say in nutshell 1 to 1. But the COVID, if you see, it was 1 to 9. So one person usually infect 9 cases. So that was 10 times usually less than the COVID-19. And similarly, the chances of getting pneumonia and bronchiolitis, they are also very less, especially the children who are having low immunity because the immunity has not fully developed, especially the general immunity and the lung immunity. Lung immunity developed in the last, even the person gets full lung maturity at the age of 21 years. So I think one has to grown up to 21 years, then you can say that my lungs are fully developed as per the lung immunity is concerned. But till 21 years, a lot of air pollution and passive smoking and so many other things, they have decreased again the local lung immunity. So that is the problem. Another thing is that this viral infection is a self-limiting infection. Usually 1 week is the time. But remember the red flag sign, as the mentioned by Dr. Ambika also, and Dr. Ravi and Dr. Dinesh, everyone has given the red flag sign that there should be, you have to, see, everybody is having the pulse oximeter during the COVID days. If you don't have, please have. This is a very important test. If you have glucometer, if you have BP instrument, then you have the thermometer, then fourth one instrument, that is pulse oximeter, must be there. It tells 2 things, the oxygen level and the pulse level. If the pulse is more than 120 and oxygen is going below 9, it's a red flag sign. And consciousness is one thing. One should not have semi-conscious or unconsciousness. So consciousness, pulse rate, oxygen, your BP falling down, these are the red flag signs. So pulse going up, BP going down, consciousness going down, and your oxygen is also going down. So only pulse is increasing, rest of the pulse, the consciousness is decreasing, the BP is decreasing, and your oxygen is decreasing. So these are the 4 very important red flag signs you should keep in mind. And of course, the prevention is better than cure. No specific treatment is available. No specific antiviral is available. No vaccine is available. So only prevention will work. So that's why we should do all preventive measures. And don't be panicked. Again, I'm saying that nobody has expired in this country by this infection. I gave you the example of Lucknow case, where a 60-year female on the dialysis, she also could survive and could cope up this infection. So nothing serious about this as far as the mortality power of this infection is concerned. And this is not a new infection. For more than 60 years, we are knowing each other, and there is no evidence that there is a new mutation. And of course, we have confidence on our doctors, on our health system. And in last 5 years, after the COVID times, we have developed a very good infrastructure and capacity building of our health infrastructure and everything. So rely upon the health system and our doctors. Don't be panicked. Thank you. Thank you very much. Thank you, Chess Council of India. It's a President Secretary. Thank you, Krishna. Thank you. Thank you, my esteemed panelists, Dr. Ambika, Dr. Dinesh, Dr. Ravi, and Dr. Parikh. Thank you very much. Thank you very much. And thank you, our technical partner, Cipla Limited. Thank you.
Thank you, sir, for wonderful moderation, sir. You took time out on day of conference also. Thank you.
And Dr. Shivam Srivastav from Lucknow, he has appreciated our efforts. So thank you, Shivam, for appreciation.
Thank you very much, sir.
Thank you.
Yeah.